Welcome to Implementing HCBS Requirements for Home and Community-Based Settings. This training is intended for DSPs and home providers. I don't know if you're like me, but often when I'm learning something new, there are words or terms that I don't recognize. On the next slide, we'll define some of the abbreviations used in this training. The Centers for Medicare and Medicaid Services, or CMS, is the federal government agency that provides funding for and oversight of New Hampshire's Medicaid system. Perhaps you've heard of the Developmental Disabilities or Acquired Brain Disorder waivers, also known as the DD or ABD waiver. They're the methods that New Hampshire uses to bill for services provided to individuals receiving services due to a developmental disability or an acquired brain disorder. Home and community-based setting, often referred to as just setting, represents the location where services are delivered that are funded through the Medicaid dollars under the DD or ABD waiver. The Statewide Transition Plan, or STP, is New Hampshire's plan to become 100% compliant with CMS's expectations for home and community-based settings. Long-Term Services and Supports, or LTSS, refers to a wide range of supports and services for individuals with developmental disabilities and acquired brain disorders, serious mental illness, or adults aged 18 through 60 who have a chronic illness or disability, and individuals age 60 or older. If you work in New Hampshire's service delivery system, no doubt you've heard of the term regs. This term is short for regulations, which are the administrative rules that govern our system. Reg HEM 310 is rights for persons receiving developmental services or acquired brain disorder services in the community. Reg HEM 202 is Rights Protection Procedures for Developmental Services. In March 2014, CMS developed new expectations for home and community-based settings, which provide services to individuals on the Medicaid waiver. Those expectations are requirements for every setting that is considered home and community-based in every state in the U.S. Throughout 2015, New Hampshire conducted a review of a sampling of home and community-based settings to get a baseline of compliance. New Hampshire realized that there were 3 areas of non-compliance within the DD and ABD waivers. Both New Hampshire and CMS want to ensure that the individuals who receive services on a Medicaid waiver have choice, control, and a good quality of life. In May of 2016, New Hampshire submitted its statewide transition plan to CMS. The plan was developed with input from a 16-member task force of New Hampshire stakeholders. The plan explained to CMS how the state will ensure that all home and community-based settings would become compliant with their expectations by the deadline. When CMS developed their expectations for home and community-based settings, they gave each state 5 years to become compliant with those expectations. In the beginning, the deadline for compliance was March of 2019. CMS realized that states needed more time to become compliant, so the deadline was changed to March of 2023. This slide highlights the HCBS requirements and rights and responsibilities education process. CMS developed the requirements in March of 2014 to ensure that individuals who receive waivered services have the same quality of life as those of us who do not receive waivered services. New Hampshire has had that same philosophy ever since the closing of the state school in 1991. So, in order to combine the efforts of CMS and the state of New Hampshire, the following process will be implemented. During the transition period, the state of New Hampshire will provide training in person and/or online for the following groups: direct support professionals, home providers, service coordinators, and families. The purpose of these trainings is to discuss the HCBS requirements and what they are and how they impact the services that will be provided to individuals in New Hampshire. Additionally, New Hampshire will be updating the Rights and Responsibilities booklet that individuals receive at their service agreement meeting. The state will also engage self-advocates to develop and deliver a training to those individuals who are receiving services. Finally, when the transition period is finished, the requirements that CMS has for home and community-based settings will be incorporated into the rights training for support providers, and the Rights and Responsibilities booklet for individuals will include the requirements from CMS as well as the state regulatory requirements for the state of New Hampshire. Here in New Hampshire, we've defined a home and community-based setting as a service setting that is funded through Medicaid dollars under the Developmental Disabilities, DD, Acquired Brain Disorder, ABD, or Choices for Independence, CFI, waivers. The first thing New Hampshire had to do was to determine which settings where services were provided were considered home and community-based. Because settings are not defined the same by every state, our settings would be different than those in Rhode Island or New Jersey or California, for example. The types of settings that were determined to be home and community-based here in New Hampshire are listed in the left-hand column on the slide, and the right-hand column shows the certification or licensing that govern them. The first setting is staffed residences and adult foster care homes. That makes sense given that these homes are really part of the community. They're certified under HEM 1001. The next setting is residential treatment or rehab setting. They're licensed under HEP 807 and are a residential option available to individuals on the ABD waiver. The next setting is community residences at the residential care and supported residential care level. They're licensed under HEP 814. These settings are where individuals who have a developmental disability or acquired brain disorder are provided supports, and there are more than 4 individuals living in the residence. The next setting is assisted living residence under supported residential health care. They're licensed under HEP 805 and are for individuals on the ABD waiver only. The next setting is community participation services. Again, community participation services are definitely home and community-based. They take place in the community. They're certified under HEM 507. The next setting is employment services, and although they're not certified or licensed, they are considered home and community-based because when you're working, you're out in the community and integrated with other people who are not served on the Medicaid waivers. And the next setting is certification of residential services, combined residential and day services, or self-directed day services provided in a family home. These settings are certified under HEM 521. And as we know, in New Hampshire, we do not tell families how to provide services to their family member. So when the state looks at certified settings under 521, they'll be looking at the day services portion only for compliance with the HCBS expectations. The day services in a 521 setting are typically provided by a vendor or an area agency outside of the home. The last setting is Participant-Directed and Managed Services, or PDMS. They're certified under HEM 525. These services are typically provided in a family home. Here we will be monitoring for isolation only. CMS wants to make sure that individuals who receive services on the waivers are not isolated from other people in the community. So part of the expectation that New Hampshire has is that those people who have PDMS services will ensure that their family member has access to the community and opportunities to be out in the community as much as they choose. CMS has told each state that all home and community-based settings must have the following qualities. The first expectation CMS has for HCBS settings is that the setting is integrated in and supports full access of individuals receiving Medicaid HCBS to the greater community, including opportunities to seek employment and work in competitive integrated settings. For all individuals that we support, CMS wants to make sure that if people want to work, they have the support to be able to look for work and obtain employment. CMS also wants to ensure that if individuals are working, they're in an integrated setting and receive at least minimum wage for the work they're providing. CMS will not pay for individuals to be working in a sheltered workshop. Engage in community life. What this means is that the individuals we support and not someone else will determine what their likes are. So if an individual is interested in participating in activity in the community, they're supported to go to the community and be part of whatever activities they choose. Activities may include things like bowling, going to a coffee shop, meeting friends, going to the movies, and so forth. If an individual is interested in something like, let's say, piano music, for example, CMS expects that they will be supported to go out into the community and go to a concert or a piano bar. CMS does not agree with someone coming into the home and providing music for the individual. CMS considers this to be reverse integration. And while this activity might be something that a lot of the individuals we support enjoy, it's not considered full access to the community. So individuals will need to be able to have access to opportunities out in the community in addition to situations where activities are brought into the home. There needs to be access to the community on a regular basis for settings to be in compliance with the expectation of CMS. Control personal resources. What this means is that any individual who receives spending money or who works and receives a paycheck is able to spend that money as they choose. What that means is that we as a service delivery system have to support their choices, even if it's not necessarily a choice that we would make. CMS wants to ensure that individuals are able to choose what they want to do, where they want to go, and be able to spend their money on those choices. Receive services in the community to the same degree of access as individuals not receiving Medicaid services. This means that individuals receiving Medicaid services should have the same access to the community, to the activities, and to the options that are available in the community as any other person who doesn't receive Medicaid services. The next expectation is the setting is selected by the individual from among setting options, including non-disability specific settings and an option for a private unit in a residential setting. The setting options are identified and documented in the Person-Centered Service Plan, which is our service agreement, and are based on the individual's needs, preferences, and for residential settings, resources available for room and board. CMS also wants to ensure that individuals have the choice of setting in which they receive services. Here in New Hampshire, we're a voluntary system and individuals have a choice over the provider of services, the area agency, and the people who provide services to them. Choice is a big part of New Hampshire's service delivery system and always has been. The next expectation is that the setting ensures an individual's rights of privacy, dignity and respect, and freedom from coercion and restraint. New Hampshire believes in the rights of the individuals that we are supporting under the DD and ABD waivers, which is why when the state school was closed in 1991, the rights of individuals receiving services in the community was developed. It outlines all of the rights that individuals have through the service delivery system. In addition, New Hampshire wanted to ensure that there was a strategy in place if someone's rights were violated. HEM 202, the Complaint Procedure Regulation, was developed to identify when complaints should be filed when the rights of an individual has been violated. The fourth expectation is optimizes but does not regiment individual initiative, autonomy, and independence in making life choices, including but not limited to daily activities, physical environment, and with whom to interact. CMS wants to ensure that all individuals have opportunities to be with people that they choose activities that they want, including activities that occur on a daily basis, such as when to go to sleep, when to get up, and when to eat. The same activities and choices that you and I have, even though we don't receive services under the ABD or DD waivers. The fifth expectation is facilitates individual choice regarding services and supports and who provides them. In our system, choices are identified and offered at the service agreement planning meeting. The individual, their family, support team, and/or guardian makes the choices of the supports they want, who's going to provide those supports, and the settings in which those supports and services will occur. CMS also identified some additional requirements for provider-owned or controlled residential setting. A provider-owned or controlled setting would be a residential setting that is owned by a home provider, an agency, or a vendor that provides services in that setting. In 2014, CMS said the additional requirements only apply to residential settings. But in 2017, CMS identified that these additional requirements apply to all settings. The first additional requirement that CMS identified, as you can see, is rather lengthy. In a nutshell, what CMS is expecting is that all residential settings will have protections in place around eviction for individuals receiving Medicaid services. CMS says that individuals should have the same protections that you and I would have if we were renting a house or an apartment. Individuals would know that they're protected. Their landlord wouldn't enter their home without permission, and they'd know that there's a specific process in place if the landlord decided to evict them. We're very fortunate here in New Hampshire because our service delivery system ensures that individuals will always have a residential setting. So, for example, let's say that there's an emergency situation on a Friday of a 3-day weekend. The provider calls to say that they want the individual out of their home because they've created holes in the wall for the last time. Well, our service delivery system will find temporary residential arrangements while they figure out a long-term plan for the individual. The next additional requirement, number 2, is that each individual has privacy in their sleeping or living unit. The slide shows 3 areas that fall under this expectation. The first, units have entrance doors lockable by the individual with only appropriate staff having keys to the doors. Lockable doors does not mean that the doors will be locked. What it does mean is that if individuals want to have privacy in their room and lock their door, they can. The expectation is that each individual will have a lockable door to their bedroom. The type of lock would be determined by the individual's needs. For example, some may have a typical lock and others may require a push-button code-style lock. It is also expected that all individuals have a key to their home. Appropriate staff means the staff working with that individual. Staff should not go home with a key to the individual's bedroom or home. CMS and BDS expect that all individuals will have locks on their bedroom doors. Any exceptions to the requirement must include all of the modification criteria. Modifications will not be allowable as a standard practice, but rather as a course of last resort. Next, individuals sharing units have a choice of roommates in that setting. Well, this has been a part of New Hampshire's HEM 310 for years. New Hampshire's been following this expectation for a very long time. And finally, individuals have the freedom to furnish and decorate their sleeping or living units within the lease or other agreement. New Hampshire has always included in HEM 310 that individuals can choose how their room is furnished and decorated. We all want to make our rooms home-like and meaningful to us, which may include having pictures of people we like, items that are meaningful to us, and decorations that we enjoy. The third additional requirement is that individuals have the freedom and support to control their own schedules and activities and have access to food at any time. All of us like to have control over the activities we do and what our schedules look like. And having access to food at any time certainly makes sense. So if an individual is hungry, they should be able to have something to eat. Even if it's 5 minutes before supper, the expectation is that they be allowed to. For individuals who may have dietary restrictions based on their health conditions, such as diabetes, there would be a modification in place, which would be identified in their service agreement. The fourth additional requirement is that individuals are able to have visitors of their choosing at any time. What a wonderful concept. Those of us who have worked in the service delivery system for a while wish that every individual they support have lots of friends, family, and visitors who come to visit them in their home. So this expectation really does make sense. Additional requirement number 5. The setting is physically accessible to the individual. Well, that certainly makes sense. But in this picture, you see a handicapped parking spot with no ramp to access the building. CMS says that if the setting is receiving funding under the Medicaid waiver, the setting must be physically accessible to the individual who is receiving supports there. So when an individual is making the choice about where they want to receive services, they may not want to choose a setting that they can't access all of the services. Here's an example of what this expectation doesn't mean. Let's say in a case where the individual uses a wheelchair but lives in a home where the laundry is in the basement. Well, even though they can't access the laundry, it doesn't mean the setting would be considered non-accessible. They could still participate in the laundry process to the best of their ability. They could collect their dirty laundry, put it in a basket, and give it to someone else to take downstairs. That person could wash and dry the laundry, bring it back upstairs to the individual who could then take it to their room, fold it, and put it away. So there are options when we think about settings being physically accessible, but certainly we want to ensure that individuals can get around in settings where they're being supported. And the final additional requirement, number 6, says that any modification of the additional conditions specified in items 1 through 4 must be supported by a specific assessed need and justified in the person-centered service plan. So there may be times when we need to restrict an individual's ability to have all of these expectations met. As an example, access to food at any time. If someone has a dietary restriction due to their health condition, we want to ensure that there's a modification in place. A modification would need to meet certain criteria to ensure that things weren't just arbitrary. Next, we'll look at the modification requirements that CMS has identified. You'll see that it truly replicates New Hampshire's behavior plan model. All modification information must be included in an individual's service agreement. This slide and the next slide contain a list of modification requirements that must be documented in the service agreement. The first is to identify a specific and individualized assessed need. Again, CMS wants to make sure that if there's a modification of these expectations, it's done for a specific reason based on that individual. The next is to document the positive interventions and supports used prior to any modification to the person-centered plan. CMS wants to ensure that if we have tried a positive intervention and it didn't work, then we go to a modification. If we haven't tried positive interventions and supports, that we try those first before a modification is made. Next, document less intrusive methods of meeting the need that have been tried but didn't work. It's really important that we document those things that we've tried but haven't been successful, so that staff who work with the individual in years to come can see that something's been already tried but didn't work. Sometimes knowledge is lost and we have to recreate or reinvent and go through experiences that are unnecessary because things were not documented. The next is include a clear description of the condition that is directly proportionate to the specific assessed need. So CMS wants to ensure that a modification is not imposed above and beyond the need that the individual has. The next item that must be documented is that we include regular collection and review of data to measure the ongoing effectiveness of the modification. If we're going to put a modification in place, we want to make sure that it's working. And the only way to know that is through the collection of data. Next, we want to include established time limits for periodic reviews to determine if the modification is still necessary or can be terminated. CMS wants to ensure that we don't continue a modification when in fact it isn't necessary. Sometimes as people change or get older, the modification isn't necessary. And then we want to include the informed consent of the individual. Well, it's perfectly normal in the state of New Hampshire to ensure that we have the informed consent of the individual or their guardian. And then finally, we want to include an assurance that interventions and supports will cause no harm to the individual. The state of New Hampshire and the service delivery system would never implement a modification that would cause harm to any individual. CMS identifies hospitals, nursing facilities, institutions for mental diseases, intermediate care facilities, and other locations that have the qualities of an institutional setting as not being home and community based. For the developmental and acquired brain disorder waivers, we have no settings that qualify as not being home and community based on the definition set forth by CMS. CMS also identified that some settings are presumed to have the qualities of an institution. Those settings include any setting that is located in a building that is also a publicly or privately operated facility that provides inpatient institutional treatment. For purposes of this particular process, CMS defines a public institution as a facility that is run by a state, a municipality, or a county government. So a public institution is not considered a school or a library. CMS also identifies any setting that is located in a building on the grounds of or immediately adjacent to a public institution. For the DD and ABD waivers, we have one of those types of settings, and it's located on the grounds of the New Hampshire Hospital. Because New Hampshire Hospital is run by the state, it's considered a public institution. CMS also identifies any other setting that has the effect of isolating individuals receiving Medicaid HCBS from the broader community of individuals not receiving Medicaid HCBS. All of the settings noted above would be considered by CMS as being presumed to have the qualities of an institution. The idea of isolation includes many settings for the DD and ABD waivers and will include a review process to show CMS that those settings may be presumed to be institutional, but truly do have the expectations and qualities of a home and community-based setting. For settings that are presumed to be institutional by CMS, a process called Heightened Scrutiny must be implemented. Heightened Scrutiny is the process used to determine if the setting can show that it does not have the qualities of an institution and does have the qualities of a home and community-based setting. The process must be implemented for settings that CMS defined as having institutional qualities. In New Hampshire, we've been proactive and identified any setting that supports more than 4 individuals as potentially isolating, so they would be included on our Heightened Scrutiny list. The Heightened Scrutiny process includes 2 levels of approval. One is that the state approves a request to CMS for Heightened Scrutiny, and then CMS reviewing the submission and approving the request. If a request is approved by both New Hampshire and CMS, ongoing monitoring of the setting will occur to ensure continued compliance. In 2015, New Hampshire had to determine how many settings were in compliance with the HCBS expectations and how many settings could be in compliance by the deadline of 2023. In order to do that, the state had to do settings reviews. It was determined that New Hampshire had a total of 913 non-residential and 1,071 residential settings. The total number of settings equaled 1,984. As we know, things change over time, so the total number of settings at this point is different than the 1,984. Of those settings, there were none that were in compliance due to the following 3 items. The first was no setting had a lease or tenancy agreement in place for the individuals that are being supported. The second is that there were no locks on bedroom doors for the individuals. And third is that at the time of the settings inventory, the service agreement didn't include the options offered for setting choices and the choice made for service providers. It's expected that New Hampshire will be in compliance with all of CMS's expectations by the 2023 deadline, and therefore no individuals will need to move from the setting where they are currently being provided services. Once the setting inventory was completed in 2015, we had a clear understanding of New Hampshire's compliance status. We then had to identify the steps we would take to meet compliance by 2023. The plan that was developed is called the Statewide Transition Plan, or STP. It was submitted to CMS in May of 2016. The first component of the STP was the status of HCBS settings in New Hampshire at that time. Once New Hampshire had identified the status of each setting, the next step was to conduct a regulatory review. The purpose of the regulatory review was to determine and let CMS know if New Hampshire's regulations were compliant, non-compliant, or silent regarding their expectations. Once each regulation was determined to be compliant, non-compliant, or silent, we've had to show how we would ensure that all regulations would be in compliance by the deadline. And this was done for the ABD, the DD, and the CFI waivers. The next step in our plan was to identify goals that we would work on for each of the areas that CMS identified. New Hampshire firmly believes that the things CMS wants for each individual in the settings is really important. Therefore, we identified goals for every topic area that CMS wants to ensure compliance with. Each goal has a timeline and steps that will be taken to ensure compliance by March of 2023. If you're interested in the full list of goals, you can go to the DHHS website, and there you'll find the statewide transition plan. The goals are attachments at the end of the plan. An additional component of our plan describes the monitoring systems that will be in place to ensure ongoing compliance. Because CMS wants to be sure that every setting continues to be in compliance after the deadline, each state had to identify how they would ensure compliance as time goes on. The final component of our plan is about achieving 100% compliance. We will do a reevaluation of every setting in the state. The reassessments will then tell us whether or not the setting is in compliance at that time. If a setting is not in compliance, the state will work with the setting to support them in following through on a plan to ensure that they are in compliance by the deadline. As we said, one of the tools New Hampshire will use to monitor how well the state is doing with the CMS requirements is the service agreement. This slide shows its sections and highlights the ones that correspond to HCBS requirements. As you can see, rep payee, personal profile, services to be provided, residential services, day services, goals, and the planning process acknowledgement form all correspond to HCBS requirements. What CMS is asking is nothing new to New Hampshire. Anyone who's lived in the state for any length of time knows that New Hampshire closed its only institution for individuals with developmental disabilities back in 1991. The reason for that was perfectly simple. The individuals in the institution deserved a better quality of life, and that quality of life was found in the community amongst other individuals who do not have a developmental disability and are not funded on the Medicaid waivers. I think all of us would agree that quality of life, choice, and control is what we all want for ourselves as well as the individuals we support. CMS is telling us what their expectations are, but for New Hampshire, we've been doing it right along. This concludes the training implementing requirements for home and community-based settings. Thank you for completing this training.